Pattern 1. You describe a pattern 1 by showing these scalloped contour. But then people make a mistake by calling it Cooper's ligament. Would you mind telling me the histopathology of just this one? How would you answer? You would say anything that is homogeneous, ground glass-like, structureless, and concave is fibrosis. I don't see the TDLUs, I don't see ducts, I don't see fat. But that doesn't justify making a mistake in terminology. Mr. Cooper was much smarter than giving his name to this, because if you do 3D pathology, then it's indeed ducts, TDLUs, and fibrosis. Now that means 3 out of the 4 basic building blocks. Dear colleagues, this is not a ligament. That's a misnomer. My Achilles tendon is a ligament. And this one may go through wintertime. So this is going to disappear. A ligament never disappears. This may show springtime, and this one is wintertime. Nevertheless, you see fibrosis, you see terminal ductal lobular units, even if they are atrophic, and you see ducts. Whenever you see 3 out of 4 or 4 out of 4, that is breast tissue. So what is a Cooper's ligament? Actually, fibroglandular tissue. If that is the case, then cancer can develop within the Cooper's ligament, from the duct, and from the terminal ductal lobular unit. Or benign lesions can develop. Here it is. Here is a cyst. Here is a small fibroadenoma. And of course, this is what it looks like on large section histology. This is the superficial fascia and this Cooper's ligament. Adenosis, that is larger TDLU, or fibrocystic change can develop in Cooper's ligament. Here is the apocrine metaplasia. And cancer can develop in Cooper's ligament. Be very careful with the very fashionable skin-sparing mastectomy. You can really harm the women, because if you do skin-sparing mastectomy, then you have to leave some tissue behind, because otherwise the skin doesn't get blood supply. And then you left cancer behind. Look at this case, for example. There is cancer in the Cooper's ligament. There is nothing in this one, but there is a lot of cancer here. This is the 3-dimensional picture, and this is the conventional histology. The cancer is growing, growing, growing all the way under the skin. This is all cancer. So if you leave that behind, you are not doing a good service for the patient. Skin-sparing mastectomy can be done in selected cases, but not to the extent it is done today. I don't think so. Look at this case. The radiologist can tell you that the cancer goes all the way to the skin. In that case, don't do skin-sparing mastectomy, because you leave cancer behind. So the so-called Cooper's ligament was one feature of pattern 1. The other one was the presence of terminal ductal lobular units. This is going to be a pattern 1 with those tiny TDLUs, larger TDLUs, large number of TDLUs, few ducts. Beautiful picture, beautiful comparison. This is still a so-called normal, let's say the upper end of the normal, and it's because it's larger, hypertrophy, and because there are many more fingers than in this one, hyperplasia. That's why we call this adenosis. What is adenosis? One of the hyperplastic breast changes where there is a hyperplasia and hypertrophy of the terminal ductal lobular unit. And that's actually the pattern 4. And when you image this one, you are going to see the varying sizes of the nodular densities. This is tiny, this is bigger, this is even bigger, and so on, corresponding to that. And here are the ducts as well. The next feature of pattern 1 is the presence of adipose tissue. And so the English medical term fibroglandular tissue is brilliant. A good radiologist doesn't look at the white, the radiopaque. You look at the black in order to see the white. If your callback rate is too high, then I believe that you are still looking at the white. Because our physiology, humans are kind of created so that we are going towards the light. Please manipulate your mind to look at the black in order to see the white. And that's a very important issue, because the artist is fooling our brain. You think it's a three-dimensional picture, but you see, actually, this is just a simple picture on the wall. What did the artist do with you? Dark and light, and dark and light, and dark and light. Well, this is a mammogram. This is a three-dimensional organ. Dark and light, and dark and light, and dark and light. So try to recreate on your mind the three-dimensional picture. And you do it by doodling, as I'm doing. You doodle for a while, and after that it becomes your second nature. This is fat. This is fat. And the fibroglandular tissue has a concave contour. When a cancer is going to grow out of it, then it's bulging at the expense of the fat. Or if it's a stellate lesion, then we got this iceberg phenomenon. Here we go. You see, it's much easier to see this than this one. Radiopaque, radiopaque. And these are the terminal ductal lobular units here, of which the disease is developed. So what you could do is that you do the inversion. White and black and black and white. Sometimes it helps. Quite often it helps. Or it actually kills boredom of screening. You see, everybody believes this is a three-dimensional picture. No, it's a tapestry hanging on the wall. The artist just lifted up. Let's practice. So we are talking about a case, pattern 1. She's asymptomatic. She's 61. She comes to your screening. This is not a fatty replace. This cannot be a 2. Cannot be a pattern 3. This is not a pattern 5. This is not a pattern 4 either. What is left? Pattern 1. In 30% of the cases, we are missing cancers in these dense breasts. What could this be? Let's say BI-RADS B. Now you looked at it for a while, and we are going to learn pretty soon a system, how to view a mammogram. And there will be 4 areas you are going to learn where most of the cancers are. Number 1, this. Behind the nipple is number 2. Behind the fibroglandular tissue, we call it the no man's land. You're not accepting asymmetric density. And then you just draw a line between nipple and the medial half. So you went through checkpoint 1, 2, 3, 4. But whenever the breast is dense, you also have to look at the contour. Stop here. Do you see any difference? I think there is something there. Right here, look at this. I think there is an iceberg. Is it sticking out? Now this is difficult. This is very difficult. Prove it. Yes, it's here. Of course, ultrasound could find it. Easy. You see how difficult it is? And if 8 or 9 radiologists sitting here out of 10 missed it, then there is no problem with the radiologist. So we need help. Look at this. Even a child can find the cancer if you do automated breast ultrasound. That's going to be the future. We are not going to miss these cancers. And taller than wide, brilliant. This is a carcinoma. And it's a unifocal carcinoma, as the MR examination shows. So then you go for it. You do the core biopsy. Only one shot, that's enough. It's unifocal. The surgeon got the message. Here is the needle going in. And the surgeon is going to remove a unifocal carcinoma, which is not larger than 10 millimeter. That's when we want to find it, when it's still confined to the site of origin. Wintertime is coming. It's a spring, and the acini decrease in number. As long as it was viable in springtime, the acini were very diligent in producing the milk, sending it into the duct, and the baby is happy. But after a while, the TDLUs, after many, many ups and down, hope and disappointment, and hope and disappointment, she won't be pregnant anymore. We retire. And that makes the radiologist very happy. That's what is called pattern 2. Wintertime. You see? And this is an absolute dream of the mammographer. You see, the ducts are there. The ducts are skinny. They don't become more or fewer. No, only the leaves are leaving. And then we can find every small cancer. Pattern 2, easy, really the dream of the mammographer. I can see the superficial fascia outlined. This one called Cooper's ligament outlined. And I can find something that has convex contour. And then we call her back and we magnify, and it says, I am a cancer. And it's just 3-4 millimeter. Very easy. If all women looked like this, we would not have a course. It looks like a sea urchin. Central tumor mass, excess amount of tissue, and the speculations. This is the 3-dimensional automated breast ultrasound. This is the microfocus magnification spot compression. Let's practice. 69. She's asymptomatic. Comes to mammography screening. Piece of cake. Stop me when you see something. Asymmetric density. Yes. But that's not enough. I'm going to call her back, and I magnify it, and I'm saying it's not only asymmetric density, but it's non-specific. That is, it's not fibrogranular tissue, so it's equivocal. And then the magnification shows its real nature. And then the ultrasound proves it's a carcinoma. So gradually we build up the diagnosis. And here is another one. That's low density, very sharply outlined. This is higher density, and it didn't shave for a week, so it must be a cancer. Even a few millimeter size lesion can be easily detected in pattern 2. The diagnosis can be made easily in pattern 2. No problem. And when you add the MR, then you still believe it's unifocal. You know that MR is not here to make the diagnosis. I already put a needle into this. I already know it's a carcinoma. I'm going to ask the surgeon to take this one out as well, which turns out to be intramammary lymph node. The MR is here to determine the extent. And if the surgeon only takes out this little, that's a mistake. Let's look at it. It still shows that it's easy, unifocal. There are no satellites, no in situ component, nothing. And that's what you believe. So you put the needle in. Indeed, this is invasive carcinoma. And fortunately, good surgeons never operate like this. So the surgeon gave enough margin. Now you magnify this, and you got this one in the so-called faxitron, very smart little machine. And so I'm looking for satellites. I don't see anything. And then the pathologist says, job well done. What you found is here. But I'm doing large section histology that is embed the entire tissue the surgeon removed. And look what I found. I found something the MR missed, ultrasound missed, namely cancer within the ducts. This is not an invasive ductal carcinoma. It's a cancer originating from the terminal ductal lobule, from the acini. So it's an acinar adenocarcinoma of the breast. And that one can be cured, but this is a tough one. So can you imagine, we all believe that it's going to be a smaller than 1 centimeter carcinoma, but actually here was a mammographically, MR-wise, ultrasound-wise, occult carcinoma within the major ducts. And that's a heartbreaking because it's about 22 millimeter. That's good because the surgeon was smart and didn't do the circumcision, but much larger area the surgeon took out. Great. Let's go for pattern 3. Dear colleagues, pattern 3, or BI-RADS B, means that about 25% of the mammogram has tissue. But you see, you should tell what this is. Well, this is a duct. This is not a TDLU. This is not adipose tissue. This is not fibrosis. So, pattern 3 is actually retroareolar distended ducts. And then you do the three-dimensional histology, or you do the ultrasound, you're going to see that it's actually fluid. Dear colleagues, this is it. Here is one duct, and then fat, and another duct, and fat, and another duct. And eventually, you could say that this is kind of a trapezoid, retroareolar trapezoid fibrosis. Especially because some of the ducts have the periductal fibrosis, so it melts together to this shape of density. Let's talk about something more difficult. You see that the ducts are prominent and the TDLUs are enlarged. Everything is very grown up. And that's pattern 4. Which means that if and when you see these big snowflake-like nodular densities, think about this one. This tiny little TDLU has 60 fingers. This one has 120 or 200. And that makes it high risk because the finger is going to be that long and there is a myoepithelial cell here and there are the luminous cells. And let me make up a number, let's say 800 in this one. And what is the number here? Let's say 2,000. More cells, higher risk. And unfortunately, these also develop more aggressive cancers. Watch out with that. So I was showing to you the pattern 1, and please compare with the pattern 4. If nothing else, compare the flowers. Large terminal ductal lobular units. There is a physiologic adenosis, and that's when she's lactating. This is the first half of the menstrual cycle, and this is the second half. So the body is preparing itself for lactation. And if she really becomes pregnant and lactates, then this is one acinus which was just this skinny, and this is what is inside its milk. So I could then ask the radiologist, now you know what the lactating breast looks like. Would you mind pulling out a piece of paper and a pen? You see how big it is, how many fingers it has? Would you mind drawing the mammographic image of a lactating breast? Then you would say, I'm going to draw a much more distended linear density, And I'm going to draw a much bigger nodular density. And here we are. And it's bilateral. You see, the TDLUs are very busy, but actually the milk is not stored here. The milk is stored in the ducts, which are surrounded by elastic tissue, rubber bands, so to speak, so it can shoot out the milk. This is what it looks like. Of course, larger TDLUs and more distended tortuous ducts, but bilateral. So you step in the room, you look at the viewing station, and you say, oh, she's a lactating woman. This is 3 years before lactation. You know, this is wintertime. The last phase of pattern 1. And look at this distance, and now she's lactating. Same woman. Look at this distance. Back, she's going to go back to this after lactation is finished. She's lactating too. Kind of towards the end of lactation, but actually you see that the TDLUs are somewhat larger and the ducts are more distended on the CC projection as well. Look how much it's going to cool down. This is it. 2 years later, 2 years before, 2 years later. I'm going to put the slides beside each other, namely 2 years difference. Before or during lactation and after lactation. Look how beautifully we can read physiology out of the mammograms. Mammograms are very sensitive images of the underlying three-dimensional histology. If it's simple adenosis, so not the pregnant, but she was born with it, she will never get rid of this pattern. And that's sad. She will always have these big, big nodular densities. And that's important for you to know about, that this is the high-risk patient, but fortunately just 12% of the population has it. So based on those 27,000 cases I classified, we figured out that when she was 45 and when she was 55, 65, 105, doesn't change. And so my friends, the statisticians, went to Singapore and tested this idea that this is a high-risk patient. And they wrote this: the study confirms the increased risk of breast cancer associated with pattern 4. This pattern is associated with nulliparity, high educational status, strongly associated with grade 3 carcinoma, also in Chinese women. Dear colleagues, this is pattern 4. I hope that gradually you understand why I dislike the simple BI-REDS pattern reading. Here, I understand the underlying 3D pathology, I understand the pathophysiology, and I can handle this differently. It doesn't change. It just doesn't. Here are 10-year difference. Didn't change at all. So, let me show you. When it was film screen mammogram, she looked like this, like zillions of beans in the bag. Here is her full-field digital mammogram. We are going to add some adjective to this. Let's say simple adenosis. Let's say sclerosing adenosis. I'm going to get back to sclerosing adenosis term later on, but let me just say it already now. Imagine that you grab the fingers of your rubber gloves and pull them out. Pull, like this. You get a broom which cannot distend. There is no cystic dilatation. Why? Because the connective tissue within the lobule proliferates and it strangles the proliferating acini, strangling adenosis, sclerosing adenosis. I wouldn't care about it if I didn't see it on the mammogram. But every single acinus might have a beautiful oyster pearl-like, called summum-body-like calcification. And the image of this is going to be this. Now you are in trouble. Because in 50% of the cases, it's benign hyperplastic breast change. But in 50% of the cases, grade 1 cancer in situ looks exactly the same. And neither you nor me will ever be able to distinguish, because both of them have the very same onion ring-like calcification. Big problem in everyday practice. So if you thought that we should have a case, then here it is. This breaks the heart of the radiologist, because you just get a well letter, normal, and just before she would be invited again, she feels a thickening. And then I say, oh, thank you very much that you found it, because she put her finger here. Do you see something very different? No. But on the CC projection you do. This is an architectural distortion. Palpable architectural distortion is either cancer or cancer. Where is it? Why don't you do 3D automated ultrasound? I think it's here. And it's here. And it's here. What is this? Well, that's very easy with the 3D automated ultrasound. You put the cursor here, and you got immediately a cancer diagnosis. But you put the cursor here, and it goes up all the way to the skin. So this is an air bubble, but this is important. That's what she felt. Much easier to see on the ABOS, automated breast ultrasound, and on the MRI. Now we are talking with the colleague, the surgeon, and we describe how close it is to the skin. Is it infiltrating the pectoral major muscle? Question mark, and so on. So the colleagues can make a right decision about the extent of the surgery. You provide all this information, and then it turns out that it's not only multifocal, but also diffuse. Multifocal is bad enough, plus diffuse. Now that's double trouble. This is not a nice cancer. But that's exactly what is so characteristic for pattern 4. Look at the extent of the disease. It's a very extensive disease, multifocal and diffuse. No family history, 46-year-old, she felt a thickening. This is a very important term. Do you see here a 10 centimeter carcinoma? 10 centimeter. Do you see or not? Which one, right or left? Of course, you see nothing. And right or left? Nobody knows. That's my point. You have to use in the future 3D automated ultrasound, which shows one and another defect. There are 2 defects here. This one we are going to talk about. This is kind of skin 2 millimeter deep to the skin, 4 millimeter, 2 by 2 by 2 millimeter. You go to the chest wall. So now you see at slide 6, that is 12 millimeter deep to the skin, you see 2 tissue defects. And one of them slowly but steadily becomes white. Why? Because it's a cyst. So you are slicing now the through transmission. That is a cyst. That is not important. But what about this one? Now that's going to be a cancer, and a huge one. Huge carcinoma. Look at this. And the mammogram was negative. That's not fair. It's not fair. Let's look at the MR. MR points out, but it's very difficult because there is enormous background enhancement. That's fine. But the MR anyway shows the lesion. And this big cyst I couldn't see here. This big cancer I couldn't see here. And you put the needle in, handheld ultrasound, obviously carcinoma, obviously invasive carcinoma. And here is the histopathology. Look at the mark of the pathologist. Goes down, down, down to the nipple. How many centimeters? At least 10. Dear colleagues, all this is carcinoma. And I see nothing. Do we need full-field digital mammogram plus automated breast ultrasound? Yes. That's an aggressive carcinoma. 8 centimeters, says the pathologist. So now you think that that was difficult, then this is mission impossible. Pattern 5. I see nothing. I don't see the birds, I don't see the airplanes, because there is a thick layer of cloud. And if it's fibrosis, why isn't it concave? Because it's pattern 5. Excess amount of fibrous tissue that hides the TDLUs, hides the ducts, and there is no fat. We all look like this. Every third cancer, we miss it. Let me entertain you with this wonderful American artist, a lady, Beverly Doolittle. You should have her book. It's full of quizzes. You see this gentleman, do you? Sure, everybody does. Do you see anything else? No. So she repainted it. Do you see the gentleman? Yeah, he is somewhere here. But suddenly, you see the eagle was here. And you missed it. And this little eagle is here. And this one is right here. Now, that's about dense breast. Fibrosis means that we have this beautiful concave contour, structuralist, ground glass-like, but that hides everything for me. I don't see the TDLUs. Look here. I don't see anything. They are there. It's a female breast. There are the ducts. I don't see that either. How frustrating. And actually, I'd like to call this a joker. Because people call it a high risk. What do you mean high risk? This is winter time. Plus fibrosis. This is no high risk. But sometimes it's extremely full of TDLUs. So we don't know what's hiding in here. Yeah, can be cancer. So now we are going to chase the contour, whether the contour is retracted, whether the contour is bulging out, whether there are calcifications and so on. Very difficult. Huge palpable tumors may be hidden in it, and huge palpable cysts may be hidden in it, like in this case. If and when she has nipple discharge, then we might be able to visualize them, but that's not fair because that happens very seldom. This is a problem. Let me show you the problem and let me give you a solution to a problem. Here it is. She's 37. Heartbreaking. She felt a lump. And she comes to you and you perform clinical breast examination and your fingers say, watch out. There is a very hard lump. There is no skin change, but this must be considered cancer. But then something, an old truth hits your mind. When a woman under 40 has a palpable cancer, think about the following. It's not only one, multifocal and very aggressive. That's heartbreaking, really. Here we go. Your fingers already told, watch out, this is carcinoma. And my eyes can see nothing. Give me a magnification. Nope, there is nothing here. CC projection. Absolutely nothing. Yeah. But that's why we have the multimodality approach. I'm going to do the 3D automated ultrasound. And here is a huge defect. And when I compared this one with the large section histology, it says 12 millimeter. I don't feel, the patient doesn't feel a 12 millimeter. There must be more here. So, next slice shows a much bigger one. So actually this poor patient had a 12 millimeter and a 29 millimeter carcinoma, and none of them were seen on the mammogram, but both of them were seen on 3D automated ultrasound. You see the ribs and the muscle among the ribs here, close to the chest wall. It wasn't seen here, but here we go. There are two cancers, and this is aggressive. Demands a lot of blood. Oh well, multifocal cancers give metastasis very often. Surgeons should know about this. Multifocality is an independent, poor prognostic factor. You put the needle in to the axillary node and you get cancer cells. Here's the MR. Although there is a tremendous background enhancement, you see here the 29 millimeter, 12 millimeter, it was palpable. Really not a big deal for the MR and the ultrasound, but it was totally blinded for the mammogram. And so one shot into one and one shot into the other one, and you go from there. Dear colleagues, this 37-year-old woman had 2 carcinomas, invasive both, too much for the body, metastasis in 2 out of 4 surgically removed lymph nodes.